welcoming Ajay Kakkar to Duke and to this special research conference. It's a real privilege to have Ajay here. He's a professor of surgery at University College London and director of the Thrombosis Research Institute, which was, I think, started by his father, who was a pioneer in really developing the concept of use of low molecular weight heparin for DVT prophylaxis, and Ajay has carried that on. And I think you have 4 major jobs, Ajay, which is pretty remarkable as a health administrator in becoming the incoming chair of the largest academic health system in the United Kingdom, University College London. As a politician, being a member of the House of Lords and the incoming chair of the Commission of Appointments, being a researcher with an educator with your institute, and being an active clinician, being an active surgeon. So it's remarkable what you're doing. We're looking forward to hearing your thoughts on academic health systems and opportunities to move the field forward. And it's terrific to have you here, so thanks.
Well, thanks, Chris, and it's a real privilege for me to be here. Thank you very much for giving me the opportunity. And I think I just press this. There we go. That's perfect. And maybe even once more. These are my disclosures, if I'll just give you a moment to study those. And this is what I plan to do over the next 40 minutes or so, and then give us some time for further discussion. I want to tell you a little bit about UCL Partners, which is our academic health science partnership, which encompasses both our academic medical centres, a number of them, and a broader population-based network. And then I want to take you a little bit to some research that we're doing, and research that we hope to continue to undertake with colleagues here at Duke on the area of thromboembolic stroke and the prevention of it in patients with atrial fibrillation using anticoagulants. So I wanted to refer to this seminal piece of work from Duke University very recently in the New England Journal of Medicine, looking at the transformation of academic medical centres, of academic health centres in an uncertain world. And Dr. Zhao basically led this very, very interesting analysis of the problems, building upon a description of how academic health centres might contribute more broadly to improving healthcare and outcomes, not only for individual patients, but populations, published in The Lancet in 2010. And there are 4 important principles that come out in this piece of work, which I think are fundamental to the way that we've started to or have been thinking at University College London Partners with regard to our own academic health science system. And they are with regard to understanding how the true academic health centres, the specialist centres, can deliver excellence in specialist care in a meaningful way that purchasers of healthcare feel it's appropriate to send large volumes of patients because they're going to have improved outcomes, and how we describe that and how we achieve those improved outcomes at the specialist level. There's a very interesting description in this piece of work about increasing research yields, because we all spend a huge amount of money on research, but what does that research actually deliver? And in terms of joining up everything that we do, are we achieving and maximising the opportunities for research and indeed the large data sets that we have in our academic centres, in our health systems, to drive a research agenda that makes research more commercially viable to deliver in rapid time and in the provision of outcomes that are going to have meaningful impact for larger numbers of patients? The third area is in terms of innovation in education and training, something that we at University College London Partners are very, very committed to. And indeed, we have taken the budget, nearly £1 billion a year, for training of all of registrars in our population area amongst the institutions that are in our partnership, to be able to drive forward an educational agenda that not only delivers top specialists, excellent general practitioners, and everything in between, but also is responsible for the training of all healthcare professionals, and allows us to embed a set of culture and values into our trainees that will help them interact with what we think the healthcare system of the future is going to be. And then we need to be much more effective at ensuring that we deliver not only in our specialist centres, but across our entire health economy, something that Dr. Zhao's paper picked up. Now, this very ridiculous diagram is a description of the modern NHS in England. The current government decided to reorganise it, and in 2012, a new Act of Parliament, the Health and Social Care Act 2012, was passed, which describes this new system. At the heart of it, you can see over here, people, patients, and the modern NHS is designed to put at the heart of healthcare the individual patient. And around it, therefore, are the providers of healthcare, primary care, secondary care, tertiary care, highly specialist providers of care, the purchasers of care, both local commissioners taking budget from government and spending it on behalf of patients to purchase their care, and specialist commissioners who buy services for specialist services provided in only a few places around the country. You have regulatory authorities that look at quality of healthcare, the regulators in terms of regulating the individual practitioner, regulating the hospital environment, regulating the financial environment in which healthcare is delivered. You then have parliamentary scrutiny, local government scrutiny. It's a little bit confusing at the moment. It hasn't all quite settled in. But what it does is spend about 110 to 120 billion pounds a year, about 9.8% of GDP, on healthcare, providing a universal healthcare service in England, which is free at the point of delivery for every individual patient. And that is a unique feature of our healthcare system. It provides remarkable opportunities for getting things right, for doing excellent research, for driving a training program of unique magnitude. But more often than not, we do get it right, but quite frequently we also get it wrong. And with changing expectation amongst the public and amongst patients, so we have major problems in terms of people's perception, taxpayers' perception, about what they're getting out of their healthcare system. Now, what is UCL Partners? Well, UCL Partners is an interesting grouping. We cover, you can see the blue over here, parts of Hertfordshire, North East and North Central London and Essex. So a large geographical area, 6 million population that represents 12% of the NHS. We have 24 healthcare organisations in our partnership, acute and mental health trusts and community providers. 21 clinical commissioning groups. Those are the local commissioners who get money from central government to buy healthcare on behalf of the population. We have 9 higher education institutions, including University College London, which is in the top 10 universities in the world, one of the 4 UK universities in the top 10 in the world. We have 26 local boroughs and councils in our partnership area, and then we have a strong industry partnership which we are continuing to build. So we're the largest academic health science system in the UK. We've chosen this partnership model unlike the other 4 initially designated academic health science centres around Imperial College, King's College, Cambridge and Manchester universities that have all gone for a much more traditional single interaction between a university institution and a large hospital. But what we have done from the very beginning, and the rest of the country have caught up in the last year or 18 months, is we've embedded our academic health science centre, which includes University College London as a leading university, Great Ormond Street Hospital, one of the top children's hospitals in Europe, and the centre of our academic medical centre for children, Moorfields Eye Hospital, which is a leading eye hospital, ranked very highly globally in terms of all the metrics we use, and the centre of our academic medical centre for eyes. Our academic medical centre for neurosciences is around Queen Square and the Institute of Neurology. And we've created 3 more for this round of designation, a new centre for inflammation, immunity and infection at the Royal Free Hospital. And then something I'm going to explain to you in a moment, a major new cardiac centre, which will be the largest in Europe at St Bartholomew's Hospital, and a major cancer specialist hospital at University College Hospital. They are all embedded, though, in our academic health science network, which is the network that covers the entire population, all the other hospitals, all the other primary care providers, all the other university institutions. So we achieve, I think, the first objective of Dr. Zhao's original Lancet paper of 2010, doing that first-in-man innovative science in our academic health science centres, or each of our 6 academic medical centres, freestanding, dedicated to a specific specialist area, supported by biomedical research centres and biomedical research units funded by central government. And then we have the capacity to flow that into our broader population rapidly, because all of this sits in a single entity, although they are separate institutions, a single holding company, if you will, called University College London Partners, which has a very small staff, just under 100, but has the responsibility for coordinating all of this activity strategically and facilitating each of our partners to deliver. And you can see here what I've said to you. We basically want to have an alignment between our NHS providers and their university providers so that we can drive forward the world-class research agenda. That's at the core of what we must do. But we also wish to fulfill the other elements, although it's, as we have discussed, very easy to say it, but also to be world-class in terms of education and in terms of patient care. We also need to deliver for our individual communities, the individual patients attending our individual hospitals. And we need to do that by understanding the continuum from the discoveries we make through to how we can make a difference for patients and influence population health. And then the third element of our obligations in terms of designation and our commitment to central government is to drive a wealth creation agenda. So there is no shame in this. It is government policy, UK government policy, that we have a major commitment as a nation to our healthcare and life sciences industry. After banking and financial services, the second most important contributor to the economy in the UK is basically healthcare and life sciences, pharma and so on. And so there is a very clear strategy defined by our Prime Minister, and I happen to be, he's just appointed me the UK Business Ambassador for healthcare and life sciences. So it is my job to promote the United Kingdom's interest in healthcare and life sciences, to attract inward investment from industry and commercial partners, and to promote not only our great universities and healthcare organisations, but the businesses involved in healthcare and life sciences in the UK globally. And I've started to travel around the world as an ambassador to do exactly that, because it's a vitally important part of the future of the United Kingdom. But it's also a vitally important discussion for all of us in academic research and in top academic centres such as Duke, to, of course, act with probity, to, of course, understand the important balance and nature of the relationship between us as academics and commercial entities, but also to ensure that we promote that responsibly, because without that kind of active relationship, we will never be able to harness for society more broadly the wealth creation opportunities that the life sciences industry offer. And I think it's a vitally important, but of course responsibly discharged part of all of the responsibility that we have in academic centres. So what are the barriers? Well, the task is massive as far as we're concerned. The bottom line problem that we started with in 2009 when we were first designated was that in our healthcare system it takes an average of 17 years for something that is proven to work in high quality clinical research to be broadly adopted across our entire healthcare system, for that system and all its patients and the health economy to be able to take advantage of that innovation. And 17 years is just too long, because by the time we've got something embedded, everything has moved on and we have to start again, de-embedding, if that such a word exists, what we've just embedded after 17 years to get the new stuff in. And we have to be able to change that. And it happens, and there are barriers that are basically because there are vested interests, we work in silos, there are funding silos, there are organisational boundaries, and at the end of the day, people just like to do what they've always done, and they are resistant to change. And they have been resistant to change, no matter how successful we are in doing excellent clinical research and providing them with evidence that they should change. And what we always forget is the failure of our ability to adopt innovation is that people die unnecessarily every day. Because either we believe the outputs of our excellent research, our excellent clinical research, huge trials, that demonstrate mortality reduction, improve clinical outcomes, and then if we don't apply that, every day that we don't apply it, somebody will die unnecessarily. And that seems a ridiculous position to be in as doctors, as healthcare professionals, that we're all in it to get the very best for our patients, and yet somehow we can't make the effort to innovate and to change clinical practice. So as I said, how have we done this? Well, government policy over the last 3 or 4 years has focused on biomedical research and the research agenda in the UK substantially. And what we have created across the geography of England are academic health science centres. They're primarily meant to do discovery. Clinical research networks that are meant to enhance the ability to get larger and larger numbers of the population into clinical trials. Academic health science networks that are there to implement best clinical practice and diffuse it across the entire health economy, and also drive the wealth creation agenda. Evaluation through applied research to be able to demonstrate to those who should rightly scrutinise our activities, the taxpayer, that what we're doing is making a big and substantial difference for them. And then we've looked at the whole way that we provide training and education in the NHS in England to develop the next generation of practitioners. Everybody else across England has decided to do all of this because we're obliged to do it, but put it into separate entities. And the view that we took is once these are separately governed, you have a major problem, because then you start to get another silo developing, or another 5 silos, with people taking control of the entity that they now have responsibility for. And these 5 vital levers don't work together. And to make a real difference, you have to leverage the funding that's available for each across the entire population. And then, by controlling what each of these does in a strategic way, you will get partners and organisations to deliver, because you control the levers to drive change. Now, that may be naive, but that's what we think, and that's how we have organised ourselves. So our Academic Health Science Centre, hopefully redesignated by Dr. Zhao last week, and therefore, Victor, you would have seen this slide in the presentation that Sir John Tooke made, that this is our Academic Health Science Centre. So it's one of those 5 levers. It is our discovery powerhouse. In it, we have 6 academic medical centres where our top science output and our top clinical and specialist clinical facilities are brought together into a managed structure to deliver excellence for, as I've said, eyes, neuroscience, and children currently, immunity, inflammation and transplantation just built at a single place. And what we're doing now is to move all of our cardiovascular activities to create the largest cardiovascular hospital in Europe at the St Bartholomew's Hospital site by closing the National Heart Hospital and the London Chest Hospital and moving it all into one place. And then moving all of our specialist cancer work for a population of 6 million into a single site at UCH with a new proton beam centre. So those will be our 6 academic medical centres going forward. And each of them has a research sub-board, a care quality sub-board, a wealth generation sub-board, education and informatics to look at all of the data available. So those cross-cutting themes are common to each of our AMCs. So that's how the partnership brings value, because what we learn in those important cross-cutting areas can be applied across each academic medical centre as we go forward. So integrated cardiovascular, as I've said to you, a huge amount of fighting going on at the moment in London. I'm one of the most unpopular people amongst cardiovascular surgeons and cardiologists, but this is something we have to do for our patients. There is no option. We have gone through a period of substantial austerity in the United Kingdom with fiscal restraint. The health budget has been protected so far, but not in cash terms it hasn't decreased, but in real terms with inflation it's getting smaller. And we have to think about doing things differently, and the only way we're going to do this is by having a single cardiovascular centre where we can deliver true excellence, from which we can run the most impressive population-based prevention programme for a population of 6 million with very, very diverse ethnicity and social status. So real distribution of burden of disease for cardiovascular disease across our population. And it's all coming together. I won't take you into the detail of it, except to say that it's out to public consultation now, and we will make this happen. So too for cancer. We are bringing together specialist cancer management at a single site. So now if I can remember it all, it's brain, it's lung, it's certain hematological malignancies, it's bladder and prostate, and 2 others. Anyway, they're all going to be done at one place. The surgeons are very, very unhappy about this because individual surgeons, I'm a surgeon, we all have excellent results. It's only somehow in the sort of general, our population does badly, and we have the worst outcomes of anywhere in the country. But we as individual surgeons all have the best outcomes that anyone has ever achieved. So it is difficult under those circumstances with people keeping their own data about their own outcomes to have the argument. So you can't have the argument, you've just got to do it. And that's what we're doing. But we will create this specialist academic medical centre in cancer. So too in mental health, because mental health is one of the major neglected areas in clinical practice in London and in the UK. Now, we're not doing mental health as an academic medical centre. We're doing mental health as something that applies across the whole system. So it's an academic health science network objective to ensure that we understand the mental health needs, not only of patients who present primarily with a mental health problem across the partnership, but also understand the mental health needs of those presenting with physical health problems, particularly chronic diseases. And we believe that that's going to have a major impact on the way that we manage these patients over time in the community and in secondary level care, and could profoundly improve outcomes. And then we have other academic health science network activities, so not delivered in the centres predominantly, but looking, for instance, at how we can, a very interesting project is how on an individual ward in every hospital in the partnership, we can have a system that allows us to identify the deteriorating patient as they are deteriorating on the ward, and have a series of systems in place to ensure that those patients are identified and we intervene in them rapidly. And as a result of doing that, we have seen, for instance, a 50% reduction across the partnership in cardiac arrest calls on the wards, because we're picking up patients at a much earlier stage of deterioration before somebody notices that something is going wrong when they have a cardiac arrest. And that's a really important cross-cutting activity, started in one institution and adopted because all the partners come together regularly. So the medical directors of all of our hospitals meet once a month. The nursing directors of our hospitals meet once a month. We share best practice. That's what the partnership facilitates. And through the sharing of that best practice, we can quickly adopt things that work in one place and apply them across the entire system. And that's how we can make a substantial difference for every individual patient. Another issue that we have started to look at is to understand what are patients, the 6 million, or amongst that 6 million population, what do patients look like? And they no longer look like, principally, people with a single disease. Rather, an aging population with multiple comorbidities. And so how do we start to address multiple comorbidities? So one of the things that we're very interested in is frailty. Because if you look at the scandals that attend NHS institutions published in our tabloid newspapers regularly, they are about frail elderly patients who are neglected for some reason in hospital. And clearly that shouldn't happen. But we've got to understand why we are seeing so many more of these patients coming into the acute care sector when they should be managed in social care in the community. So we have started to look at the development of a value scorecard for frailty, which we're starting to pilot, and I'll show you some of that work at the moment. What that allows us to do is to talk to the frail elderly and understand what they value in terms of the care that they need to be provided, and then have that as a scorecard to test our institutions by. So it's consumer-driven determination of the outcomes that our patients are looking for, as well as our clinicians, and that's vitally important. We're very much into understanding better and training all of our trainees to better handle end-of-life care questions. Because at the moment, end-of-life care is a bit of a disaster in the partnership, in that elderly people who shouldn't be in hospital are brought to hospital as a default by the ambulance service, placed in the accident and emergency department, and then put a huge pressure on in-hospital resources. And working across the partnership, we can start to both better understand how we can do better end-of-life care for large numbers of frail elderly people who are inevitably going to die. That's just the natural history of their disease. And to ensure that that is better done by coordinating services and keeping patients out of hospital and at home. And then we're looking at care homes, because care homes are a huge source of inward referral to hospital. The people who run care homes basically see somebody who's not well and phone an ambulance. And all an ambulance can do legally is bring somebody to hospital. So you can start to understand why things are not going well. And we have big interest also in homeless, because we have quite a large homeless population in central London. And we need to understand their healthcare needs, because we find, as a partnership across our acute receiving hospitals, that they disproportionately take a large amount of resource. And we spend that resource, of course, because they're decent human beings who must be looked after. But as soon as we discharge them back into homelessness, and they're very rapidly back into our hospital systems again. So those are the kinds of things we look at. And this is very interesting. This is the system map of a frail old person arriving at one of our district hospitals on the border of outer northeast London. And quite frankly, it's very complicated. And no one has ever bothered to map the journey of these people. So this is what we did. We looked at a cohort. This is what the partnership did. Some of the bright people we have working at the core of the partnership. 500 consecutive 75-year-old plus people attending at the A&E department at Queen's Hospitals out in Romford in Essex between the 3rd and the 12th of November this year. And they participated, a good number of them, nearly 300 in interviews, completed the interviews, and it's fascinating to see. Now, you see, what people say is Monday in A&E is the busiest day, and that's why everything goes wrong. And it always goes wrong because people haven't been able to access their GPs over the weekend. But actually, if you look at the arrival of these frail elderly people across the week, it is consistent every day of the week between 9 and 3. So there's nothing about this. People say, and therefore chief executives say, well, we've got to have lots more staff in A&E on Monday. And so suddenly you distort the rotas and everything that happens in the hospital for the rest of the week so that you can have everybody there on Monday. And there's no different attendance of these patients on Monday from any other day of the week, but no one has ever established this before. Then they basically say that we have a large migrant population in London. Since people don't understand the culture of using the NHS, it's a large number of migrants new to the UK who have come from healthcare systems where the thing to do is go to hospital. That means that they're just going to hospital, not phoning up their GPs. Well, look, the reality is that 98% of people in this survey were white, British-born in the UK, attending A&E as their first port of call. So again, you can blow another myth out of our healthcare system, which is that we have a major problem with migrant health, and that we therefore have to do something and spend huge amounts of money training people who are new to the United Kingdom that they should use their healthcare system. Well, they don't use it badly anyway. They tend to be the people who go and find a GP and go and see them first. And then the opposition has criticised the government for setting up a new emergency telephone number. In the UK, if you have an emergency, you phone up 999 and you get fire, ambulance or police. And they ask you that question first, and then they send an ambulance or a policeman or whatever you need. The government started 111, which is you're meant to phone up and get some good clinical advice over the telephone rather than having to go to hospital. And everyone says, or the opposition have filled the newspapers with the view that there's the 111 system that's failing, and therefore accident and emergency departments are under huge pressure. Well, the reality is, of all of those cases that underwent interview, some 300, only 6 people actually called 111 first. So it's not that 111 is being phoned up and they're so incompetent they're telling 300 people to go to A&E at Romford. It's the fact that nobody bothers to phone that's the issue. So if you look at it also, a quarter of these frail elderly attended because they'd fallen over. And the default is, if an old person falls over at home, send them to hospital. But you could imagine having a frail elderly service, some smart healthcare professional going round to see the patient at home and making an assessment about whether they need to come into hospital, rather than sending them to hospital, because once they're into the system, more frequently than not, they end up staying, which is a bit of a disaster. what's interesting is that 50% of those elderly who attended because their carers phoned the ambulance and put them in it. So you can see that in terms of social care in the community, we can do a huge amount in our healthcare systems by working more closely with carers and training them to understand what they should look for and giving them the confidence to interact with our healthcare system so that we can share responsibility in terms of taking the blame for keeping patients out of hospital. Because what they worry about, of course, is the liability of not having sent somebody to hospital. What we need to do is to share that liability with them because it makes sense for our healthcare system to keep those people out of hospital. 100% of care home initiated attendances called an ambulance. So there must be more that we can do in terms of training our ambulance service to keep patients out of hospital, even if it means, again, sharing liability with the hospital. And only 7% described a problem in not being able to talk to their general practitioner, which resulted in patients coming forward. And you can see that 60% of those who turn up in A&E are admitted to hospital. So there is an awful lot, even working as a partnership and starting to think about this type of practical analysis that we can start to do to transform the way that resources are used in our healthcare system. And so what are we doing? Well, we're looking at the relationship between ambulances and care homes. We are developing a way of talking to carers and those who look after patients in the community to understand that we will share the liability. We're developing a Frailty Academy so that we can start to train people who are carers for the frail elderly to better understand when they need to be worried about them and when they can afford to allow them to remain in their care environments in the community. We're developing across our entire system now an approach to the frail elderly that will involve general practitioners, named clinicians for the frail elderly who are living in the community, a better understanding of the dynamic, changing circumstances of those individuals so that those looking after them have a named clinician to phone who understands the case rather than only calling an ambulance to bring them in to hospital. And of course, we're doing the development of frailty models. Now look, in neurosciences, which is an academic medical centre activity, we have developed a major interest in multiple sclerosis. New biological interventions have been developed experimentally, taken through clinical trials, and are now available for our population and globally for use, and are making a difference. But we've also reconfigured stroke care in our partnership. And what we've basically done, as we're trying to do now for cancer and cardiovascular, is to say that we need to get away from every hospital admitting patients who've had an acute stroke. And we did that, and we basically got to a place where we created a single hyperacute stroke unit for the entire North Central and North East London area at University College London Hospital. And that, of course, has all the radiology in it, so every patient comes in and gets scanned by a neuroradiologist. And we've increased the rate of thrombolytic therapy for acute ischemic stroke as a result, and we have substantially reduced, so that's what we've done basically. We've sort of mapped it all and got to a place where we have a hyperacute stroke unit. After 72 hours, patients go from there to a stroke unit and then to predefined rehabilitation services. And what we've done is we've reduced our 30-day mortality from 15% to 9% just by doing that. That's a big impact on stroke mortality. We've increased our lysis rates from 3.5% of patients across the partnership hospitals to 14% just by having everybody who has an acute stroke coming to our hyperacute stroke unit. And we have, in the first 90 days, reduced the cost of acute stroke care by 6%. So people say that we've achieved all the objectives, improved outcomes, because I haven't been able to show you, but we're getting better functional outcomes for these patients, a lower mortality, and we're reducing costs. So it does show if you can work as a system, driven by the expertise of an academic medical centre, but then translating that to your entire healthcare network or system, you can make a substantial difference very quickly. Now, what about clinical trials? Well, this is very interesting. We were the worst performer at approval for clinical trials and patients going into clinical trials 3 years ago. We are now the best performing network in the country. How have we done that? Because we have gone to a single sign-off. So at UCL Partners, for the 24 organisations in the partnership, there is a single sign-off for a clinical trial. So what that means is that as a sponsor, academic or commercial, you come to the trial centre office, you go through the research governance procedure and the ethics procedure at a single place. And once you get sign-off, that is sign-off to enter a patient into that protocol at any one of our partner organisations. And that is a vitally important facility, very attractive to commercial sponsors, very attractive to academic sponsors, very attractive to our clinicians, who don't spend months or years waiting for approval for their protocols. And our average time now, mean time, for approval of a commercial study is 17 days in the partnership. So from opening your file in the research office to getting approval, it's 17 days. But West Anglia, which is just up the coast from us, is 91 days. But our national guidance is to get it done in 30 days. So we've come well below the national guidance by going for single sign-off. Now, how does this thinking translate to something that I'm interested in my own research, which is stroke? Well, look, this is the mapping of the problem of adopting innovations in anticoagulant therapy to prevent thromboembolic stroke in patients with diagnosed atrial fibrillation. And I'm not going to take you through all of it, save to say that we started with looking at the patient perspective in terms of knowing who has atrial fibrillation, in understanding how they're managed, on looking at what the guidance is. Our guidance is very clear. The National Institute of Health and Care Excellence, NICE, has said that the new oral anticoagulants are not only effective and safe for preventing stroke and atrial fibrillation, but they're highly cost effective when you look at the entire health economy. And the guidance is to make a novel anticoagulant the default intervention in preventing thromboembolic stroke. But it doesn't happen. And so we've mapped all of this, we've understood how we basically are doing at the moment, and we're now defined the outcomes that we're going to adopt and how we're going to measure application of the interventions to change practice in terms of the outcomes we're achieving for our patients and populations. And this comes to research. The Garfield Registry is something that we established about 3 or 4 years ago, which is a prospective observational analysis of eventually 55,000 patients with newly diagnosed atrial fibrillation in 1,000 randomly selected sites in 34 countries around the world, consecutively newly diagnosed patients, prospectively followed for at least 2 years and up to 8 years because of the length of the program. And we have no selection criteria at all for these patients because they have diagnosis of AF and their clinician thinks they're at risk of stroke. And then they're followed with site data verification of 20% of the data for all of these patients, a massive undertaking in an observational registry. And these are the countries now we're into the third cohort, so 34 countries, reasonably well distributed around the world. We hope to work in alliance with your marvellous Orbit AF registry here because, of course, you have the largest prospective US knowledge. And you can see how we've organised ourselves, and this slide's a bit out of date. We're at about 26,500 patients out of 55,000 in the programme now, and into the third cohort. You can see sequentially over time with this cohort design we can start to track the adoption of innovation, of novel strategies to prevent stroke in these patients around the world and describe outcomes outside the clinical trial environment. Now what's striking is, I'm not going to show you a lot of data, but it's this type of data that are starting to help inform what we do at a local level in our academic health science network. So there is a real advantage to the global research that one end of the spectrum of our academic health science centre can do in terms of running massive global clinical studies, in informing ultimately how we develop strategies to impact on the individual patient's opportunity to have a good clinical outcome by preventing stroke in the background of atrial fibrillation. And this is fascinating because if you look here, you see in cohort 1, which is accumulated between 2009 and 2011, 60% of patients were receiving alone or in combination with antiplatelet therapy and anticoagulant when they had diagnosed atrial fibrillation and were at stroke risk. That means 40% were not. You can see that with increasing risk here, this is the CHADS-VAS score, you get a modest, but yes, you do get an increase in the utilization of anticoagulation to prevent stroke. But even in the highest categories, about 40% of patients are not being protected. And if you believe the CHADS-VAS score, the annual stroke risk in that population is in excess of 20%. And our clinical colleagues around the world are giving them nothing to prevent it that's meaningful, that would work. In cohort 2, for the 18 months subsequently, you can see that nothing much changes. You still have about 62% of patients overall receiving nothing. You still have over here the low-risk patients, CHADS-VAS of 0, over 45% being anticoagulated when there's no benefit to anticoagulation at all in those patients. All you give them is bleeding risk. And what is interesting is the pattern of adoption hasn't changed. These red bars are the new anticoagulants being adopted around the world. But all that clinical colleagues are doing are swapping warfarin for one of these new agents. They're not actually using these new agents, which are more safer and more effective, to increase the number of patients they protect against stroke. That really is quite worrying, because what it shows us is all the brilliant trials, you've run 2 of them from here, Rocket AF and Aristotle, between them nearly 40,000 patients randomized against warfarin, demonstrating huge, impressive gains in efficacy, safety, and mortality reduction. And yet clinicians around the world are not looking at those data from the clinical trials and saying, I'm more confident now to anticoagulate my patient at stroke risk. All they're saying is, the ones I would have anticoagulated, I'm now going to give them one of these new agents. So there is a lesson in that for all of us in terms of how we get research into practice. I'm not going to take you through those data because I know we need to have some time for questions. I'll just tell you about this. But this is a fascinating observation and just shows what you can do even with a data set just of 25,000 patients. This is from cohort 1, where we had just 10,000 patients looking at the 5,000 true prospective followed from within 30 days of diagnosis of their AF, of which about 5,000 came into the registry with newly diagnosed AF and no recent acute coronary syndrome. But about 10%, just under 600 patients, had a new ACS diagnosis as well as a new AF diagnosis. A very interesting population, because our recommendations about how we anticoagulate and prevent recurrent or first thrombosis in those 2 different populations is substantially different, although we're affecting the same blood in the same circulation. And you can see here the characteristics of these 2 populations. Interestingly, you see the ACS patients are a bit older, they have more heart failure, they have more peripheral arterial disease, and they have higher CHADS and CHADS-VAS scores because they have more cardiovascular morbidity associated with their disease than patients presenting just with AF. If you look at the way that these patients have their interventions managed, you can see the red bars here, vitamin K antagonists alone, 40-odd% in the no ACS population, 25% in the ACS population. You can see that 25% of patients who've had an ACS have a combination of a vitamin K antagonist and antiplatelet therapy. So you can start to see that these patients are managed differently. They represent interesting challenges if we want to manage them with the new anticoagulants, where there is considerable difference in the dosing regimens for managing a patient with atrial fibrillation and managing a patient with a new ACS event in terms of their bleeding risk. But what is interesting is if you look at the unadjusted data here, and there's a very, very big issue about whether we should adjust for all the CHADS-VASc factors in an observational study between the two groups, ACS and no ACS. But I think it's more instructive to look at these unadjusted data because you're looking at the patient in front of you rather than adjusting for all of the other factors that make up a risk score. And what you can see over here is that the mortality is higher in the first year for a patient who comes into this registry having had a recent ACS and newly diagnosed AF than those with AF alone. Their stroke rate is double. Their major bleed rate, because they're receiving dual antiplatelet therapy and an anticoagulant probably, is higher. And their risk, of course, of having a recurrent event is much greater, 5 times as great. So in terms of, for our population, understanding where we need to put effort in terms of directing outpatient resource to better manage potentially cardiovascular comorbidities to improve outcomes, you could argue that this type of registry data would inform a health science system approach to a much more targeted and rigorous follow-up of patients with AF and ACS to drive improved clinical outcomes because they're so much worse. And it's probably, although I can't answer this from the registry, it's probably because we manage their comorbidities not as aggressively as we should, that the cardiovascular comorbidities are driving poor outcome in these patients. So I come back to, I think, this rather interesting article from your own institution, in summary, because there is a very big challenge that faces institutions like Duke and your academic health science system and UCL Partners, because we sit at the pinnacle of investment in healthcare systems. We enjoy some of the very best resources, some of the most talented healthcare professionals working in our institutions. But we have to transform the way that we do business. We have got to be absolutely relevant to the excellence agenda in terms of practice, research, and training. But we also have to be absolutely relevant to the broader healthcare system. And we have got to demonstrate year on year, I would say month on month, transformational interventions into our broader systems, having shown the leadership to bring those systems together, if we're going to continue to justify the existence of these hugely impressive academic medical centres and healthcare systems. Thank you very much indeed.
Great, thanks, Ajay. That was terrific, and I'm sure stimulated a lot of thoughts and ideas. And it's terrific to see how another institution across the ocean is dealing with many of the same issues that we're up against. And we'll open it up for comments or questions.
Lord Kakkar, that's quite a tour de force, your presentation. Really enjoyed it. I think you've taken on some of the critical issues that we all face and demonstrated how you've been able to move from a center approach to a network connected approach, from using the center as the innovator to drive population health. It's very impressive. I thought that I think you've demonstrated what we believe is a concept of learning health system. That is to say that you've taken, for example, the frail elderly's information, all the AF, data from your cohorts, and to look at trends and drive, in fact, changes in order to move forward, say, healthcare redesign, etc. And I think the AF data shows two things, in my opinion. One is that you're able to look at, from your registry data, your cohorts, the trends, and then secondly, that you actually illustrate very strongly that we're not doing well with implementation, right? Yeah. Because you saw your two cohorts still have the same data despite changes in medication, etc. So how would you now help the practitioners to move towards using the data to improve implementation and healthcare delivery?
Well, I think you're absolutely right. That's the big challenge for us. So what we're trying to do in our partnership is we have taken one area, which is Camden, which is an area in Islington, a slightly younger population, but still enough of the target group of AF patients. And we're designing interventions at a practice level. So we spoke yesterday about your very big commitment to informatics and data here, and how you've first applied that across the provider institutional element of your healthcare system. What we have done, because it's just how it happened in London, is we have electronic records in primary care. So what we're doing is to bring together all of the population information we have on our patients at the primary care level, and using that now to understand how the individual GP is managing the individual AF patient, and then alerting them to the fact that they are not practicing in a way that would necessarily achieve the best outcomes for that individual patient. So we have enough data now on all the patients in that locality who are over a certain age, diagnosed with atrial fibrillation, with their risk factors and how they are being prescribed, to understand both how to talk to the individual doctor about managing their patient, but also understanding outcomes year on year, a year in the life of those patients, to be able to demonstrate more broadly how individual practice in a individual GP's clinical practice can have a detrimental impact on the population outcome and population health resource utilization.
Thank you so much. I'm interested in how you're managing individual change. So for example, a lot of your data has to do with maybe delivering a message to a physician that he or she is not at the level of care that they think they are. So how are you approaching communications?
Well, we're hopefully managing it sensitively. And we're at the beginning of that journey for much of what we have to do. And a lot of this first 5 years of being an academic health science system has been to get to a place where we've understood the magnitude of our problem. Have we communicated with individual superstar clinical researchers who have done it brilliantly the way they want to do it, working at Queen Square as a top neurologist for the last 20 years, don't believe they need any help in changing the research governance structure for their work? But you can't allow one guy to continue to do it the way he wants to do it and insist the rest of the system comes to single sign-off. You just have to have personal conversations with these people, and people have to understand at the end of the day that first and foremost, there's only one real purpose, the North Star for all of us, which is our patients. There is no point to be in healthcare if you aren't in it for patients, number one. And so if it becomes about you, you've got to ask the question, why are you doing this? Number two, that ultimately no institution, no matter how famous it is in our system, is more important than any other, as far as we're concerned. And that's why it's good to have the company small but quite powerful, as UCL Partners, driving the agenda, because we're absolutely equal. You know, our view is that everybody is equal. I have no view that the chairman or the chief executive of UCH is more important to the partnership than Queen's Hospital out in Romford. Because at the end of the day, both institutions look after human beings, and both sets of human beings in our population deserve access to the best healthcare. And so when you get it down to that simple set of values, that's what, I mean, to answer your question, UCLP is the custodian of our values. And we are a values-driven entity. And the day we allow our values to be eroded, we have no currency. So we have no power, but we have huge authority because we're seen to be values-driven. And everyone understands that. So when we have a conversation with people, be it an individual or an institution, it's on the basis of those values. And the moment you allow those to be compromised or eroded, you lose your ability to influence, you lose whatever power you have, and then the whole thing will collapse.
Excellent talk, thank you. There's so many very interesting and provocative things that you've said. I feel like I'm at a rock concert here, getting feedback. So I wanted to pick up on a different issue, something that you said earlier when you mentioned that you were the ambassador.
Yeah.
And so the UK health industries as a way of generating wealth, employment, and growth.
Yeah.
Yet you have the need to continue to constrain the spending internally on healthcare. So how do you balance the fact that you don't want to actually personally spend the money to support your industries the way we do with it? We don't have price controls or volume controls the way you do.
So what I think we have to show industry is this. That we have, for instance, something called I don't know what it's called, patent box or something. If you're a pharma company and you do your discovery in the UK, you will then pay a substantially lower rate of tax on the profits you make from the promotion of that innovation. So that's one sort of commercial approach that's been taken. There are large opportunities for co-funding for research activity. In terms of the healthcare system itself, all the academic health science networks are now obliged to demonstrate every year 3 pieces of nice guidance that they have diffused across their networks and 3 high-impact innovations they have embedded in clinical practice across their networks. Nice guidance is very fair. If interventions are cost-effective, it says so, and the prices that are available for industry on cost-effective interventions and the whole area of value-based pricing is now starting to be looked at much more. So we're looking at different models by which industry, if it can demonstrate real clinical gain through the intervention, could achieve a better price or a better formula for the introduction of their innovation. So you're quite right. We do live in a constrained system, and you're quite right. It's only Americans in the world who pay the full price for innovation. The rest of us live off your generosity. But that's just the world we live in at the moment. And it provides you with the moral authority to be the world's leaders. So I think that, but we are having very active conversation with industry to make it attractive. And one of the things is to ensure if the innovations that have been demonstrated to work are properly adopted across the NHS, that will drive their commercial benefit. It will also be good to us because it will drive down our costs, because innovation improving outcomes will ultimately reduce costs. So that's a simple formula we're trying to sell them.
Excellent. Eric?
So I have no question, but to thank you very much for coming out here and visiting with us. I think people have had an opportunity to spend time with you and will the rest of your visit here be honored and privileged with your knowledge. And certainly it was an interesting one for us as we sit here and struggle with very similar issues as you mentioned with Duke and the healthcare system, and ultimately with us involved on clinical and research and education side. So thank you very much. A small token.
Oh, thank you very much. Very, very.